Hi everyone, welcome to PharmaGrid. So today our discussion topic is adverse drug reactions. So in this session we will learn about the definition of adverse drug reactions, adverse drug events, medication errors, side effects, then classification of adverse drug reactions, then how we can identify ADRs and how we can manage them, and the pregnancy categories. So everything we will discuss in detail in this session. First of all, we will see the definition. So as per WHO, that is the World Health Organization, defines ADR as a response to a drug which is noxious and unintended and which occurs at doses normally used in man for prophylaxis, diagnosis or therapy of disease or for the modification of physiologic function. So in simpler terms, we can say that an adverse drug reaction is a response or reaction to a drug which is noxious and unintended. Unintended means it is not the intended therapeutic outcome or therapeutic response of that particular drug. So this ADR means it is a response to a drug which is noxious and unintended and occurs at a normal doses used in man. And next definition is by the ASHP, that is the American Society of Health System Pharmacists. So as per ASHP, adverse drug reaction is any unexpected, unintended, undesired or excessive response to a drug that requires discontinuing the drug. It can be therapeutic or diagnostic, requires changing the drug therapy, requires modifying the dose except for minor dosage adjustments, necessitates admission to a hospital, prolongs stay in a healthcare facility, necessitates supportive treatment, significantly complicates diagnosis, negatively affects prognosis or results in temporary or permanent harm, disability or death. Next one is adverse drug event. Any untoward medical occurrence that may present during treatment with a pharmaceutical product but that does not necessarily have a causal relationship to the treatment. So this is the definition of adverse drug event as per World Health Organization. An ADR is a type of adverse drug event whose cause can be directly attributed to a drug and its physiologic properties. A causal relationship is suspected for an ADR, but it is not required for an adverse drug event. Okay, so this is a very important point. Causal relationship in the sense, suppose if there is a reaction occurs due to a drug. Okay, due to a drug, the cause is the drug. Okay, so in case of ADR, a causal relationship is there. But for an adverse drug event, the causal relationship is not required. Adverse drug events may result from medication errors or from ADRs in which there was no error. So here let's see an example that will help you to easily understand the difference between adverse drug reaction and an adverse drug event. For example, a patient taking warfarin, which is an oral anticoagulant, for pulmonary embolism, goal INR is 223, presents to the emergency department with a major bleeding episode. If the patient's INR is within therapeutic goal range and no other contributing factors to bleeding are identified, the bleed is defined as an ADR and the warfarin therapy is discontinued. Okay, so here there is a causal relationship. The patient is not taking any other medicines or there is no other contributing factors. So here we can confirm that or there is a causal relationship between the bleeding and the warfarin therapy. So this is defined as an ADR or an adverse drug reaction. There is a causal relationship between the drug and the reaction. So here as a treatment option the warfarin therapy is discontinued. Warfarin cannot be reinitiated and rechallenged in this patient. Let's take the next case. If however the patient has a supratherapeutic INR of 6 because of a drug-drug interaction with a newly prescribed antibiotic, the bleed is defined as an adverse drug event. Okay, because here we cannot say that this bleeding episode or the supratherapeutic INR is due to the warfarin alone. Okay, it can be due to the drug-drug interaction between warfarin and a newly prescribed antibiotic. Okay, so here we cannot predict or we cannot say that there is a causal relationship. Hence, this reaction or this condition is defined as an adverse drug event. And here, the warfarin therapy is temporarily interrupted until the INR decreases and the bleeding resolves. The physician may then choose to reinitiate the warfarin therapy at a lower dose to achieve a therapeutic INR. How does an ADR differ from a side effect or allergy? An allergy is an adverse drug reaction mediated by an immune response, for example, rash, hives, etc. A side effect is an expected and known effect of a drug that is not the intended therapeutic outcome. A side effect is any effect caused by a drug other than the intended therapeutic effect, whether it can be beneficial, neutral, or harmful. Any unintended effect of a pharmaceutical product occurring at normal doses which is related to the pharmacological properties of the product and in which there is no deliberate overdose. However, when side effects are severe, the reaction is termed adverse drug reaction. It is often used interchangeably. Now we will see some more definitions. Adverse drug reaction case report. So this is a case report in ADR monitoring program, which is a notification relating to a patient with an adverse effect or laboratory test abnormality suspected to be induced by a medicinal product. Next is the benefit risk analysis. Examination of the favorable or benefit and unfavorable results of undertaking a specific course of action. Signal means reported information, at least 3 spontaneous case reports on a possible causal relationship between an adverse event and a drug, the relationship being unknown or incompletely documented previously. This is known as a signal. Then unexpected adverse drug reaction means an adverse reaction, the nature or severity of which is not consistent with the applicable product or mentioned in the summary of product characteristic or market authorization or expected from the characteristics of the drug. Drug toxicity describes adverse effects of a drug that occur because the dose or plasma concentration has risen above the therapeutic range either unintentionally or intentionally, or it can be said that drug overdose. Drug abuse is the misuse of recreational or therapeutic drugs that may lead to addiction or dependence, serious physiological injury such as damage to the kidneys, liver, heart, then psychological harm in the sense abnormal behavior patterns, hallucinations, memory loss or death. Now what do you mean by medication error? Any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient or consumer. Medication errors are mishaps that occur during prescribing, transcribing, dispensing, administering, adherence or monitoring of a drug. Examples of medication errors include misreading or miswriting a prescription. Medication errors that are stopped before harm can occur are sometimes called near misses or close calls, or more formally a potential adverse drug event. Not all prescribing errors lead to adverse outcomes. Some do not cause harm, while others are caught before harm can occur. Such medication errors are known as near misses. Classification of ADRs. So the first one, based on the duration, ADRs can be classified as temporary, persistent or permanent. For example, visual loss with quinine, ethambutol and amiodarone. Next one is based on the incidence or frequency. Based on this, ADRs can be classified as very common, common, uncommon, rare and very rare. Very common means greater than 1 in 10 patients. Common means greater than 1 in 100 patients. Uncommon means greater than 1 in 1000 patients. Rare means greater than 1 in 10,000. Very rare means 1 in 1 lakh patients. Next one, based on the onset of event, ADRs can be classified as acute, subacute and latent. Acute means occurs within 60 minutes. Subacute means the ADRs that occurs within 1 to 24 hours, and latent means greater than 2 days. Next one, based on the location. Based on the location, ADRs can be classified as local and systemic. Adverse effects may be local. Local in the sense limited to a certain location, or systemic, where a medication has caused adverse effects throughout the systemic circulation. For example, some ocular antihypertensives, although administered topically as eye drops, cause systemic effects as a fraction is absorbed to the systemic circulation. Based on the severity of reaction, ADRs can be classified as mild, moderate, severe and lethal. Mild means adverse effects are transient in nature and generally do not interfere with the normal activities. They require no change in therapy, for example, sedation due to antihistamines. Then moderate means adverse effects are sufficiently disturbing and interfere with the normal activities of the patient. They require change in therapy, additional treatment, hospitalization, for example, vomiting, tachycardia or bradycardia seen with a drug, cough with angiotensin converting enzyme inhibitors, and optic atrophy due to ethambutol. Severe means these are incapacitating, disabling or life-threatening adverse effects such as anaphylaxis, hypertension and death. Seriousness is a measure of the degree of harmfulness of an adverse response to a drug, whereas severity is a measure of the intensity of the effect or response to a drug. Lethal means directly or indirectly contributes to the death of the patient. Now we are going to discuss the most important classification of ADRs, which is the ABCDEF type classification, or we can say that classification based on the types of ADRs. So here you can see A means augmented. Okay, A means augmented, or otherwise we can call it as dose related. So features of type A includes it is a very common type of adverse drug reaction and it is related to the pharmacological action of the drug, in the sense exaggerated pharmacologic response, and it is predictable and low mortality. Examples of type A or augmented type of adverse drug reactions include dry mouth with tricyclic antidepressants, respiratory depression with opioids, bleeding with warfarin, serotonin syndrome with SSRIs, then digoxin toxicity. Then the management includes reduce the dose or withhold the drug, then consider the effects of concomitant therapy. And the next type is type B. B stands for bizarre. Okay, it is non-dose related and the features include it is uncommon, it is not related to the pharmacological action of the drug and unpredictable, high mortality rate. Examples include immunologic reactions, anaphylaxis to penicillin, idiosyncratic reactions, malignant hyperthermia with the general anesthetics. So management option is withhold and avoid the particular drug in future. Next is type C. Type C stands for chronic. Chronic in the sense dose related and time related due to the chronic use of a particular drug. Features include uncommon, related to the cumulative dose. Examples include hypothalamic pituitary adrenal axis suppression by corticosteroids, then osteonecrosis of the jaw with bisphosphonate. Okay, so these types of reactions occur mainly due to the chronic use of a drug. So management option include reduce dose or withhold, then withdrawal may have to be prolonged. Now D. D stands for delayed. Delayed in the sense time related. Okay, time related. So features include it is uncommon, usually dose related, occurs or becomes apparent sometimes after the use of the drug. Then examples include carcinogenesis, tardive dyskinesia, teratogenesis, leukopenia with a low mustin. So the treatment option is often intractable. Often intractable in the sense it's usually difficult to treat. Next is type E. E stands for end of use. End of use, or otherwise we can say that due to the withdrawal of a particular drug. Features include uncommon, occurs soon after withdrawal of the drug. Examples include withdrawal syndrome with opiates or benzodiazepines, for example insomnia, anxiety. Treatment option include reintroduce the drug and withdraw slowly. Then the last one is type F. F stands for failure. Unexpected failure of therapy. Features include common, dose related, often caused by drug interactions. Examples include inadequate dosage of an oral contraceptive when used with an enzyme inducer. Then resistance to antimicrobial agents. Treatment option is either increase the dosage, then consider the effects of concomitant therapy. Then based on the mechanisms, most areas, that is 80% are type A and fewer areas are type B. The common mechanisms are abnormal pharmacokinetics. Pharmacokinetics involves absorption, distribution, metabolism and elimination. So abnormal pharmacokinetics due to genetic factors. Abnormal drug metabolism may be due to inherited factors of either phase 1 oxidation or phase 2 conjugation. Then inheriting abnormal butyrylcholinesterase or pseudocholinesterase may affect succinylcholine metabolism. Then inheriting abnormal N-acetyltransferase which conjugated phase 2 reaction. Some drugs to facilitate excretion may affect the metabolism of drugs such as isoniazid, hydralazine and procainamide. Pharmacogenomics is the study of the inherited basis for abnormal drug reactions. Next one is the protein binding. Some drug interactions with warfarin are due to changes in the protein binding. Then third one is the comorbid disease states. Various diseases which cause renal or hepatic insufficiency may alter drug metabolism and produce adverse drug reactions. Next mechanism is due to the synergistic effects. So the first one is drug and disease interaction, that is interactions between a drug and a disease. Then drug-drug interactions. Patients have abnormal metabolism by cytochrome P450 due to either inheriting abnormal alleles or due to drug interactions. The risk of drug interactions get increased with the polypharmacy. Two drugs may have synergistic actions. For example, prolongation of the QT interval by haloperidol, then selective serotonin reuptake inhibitors and estimazole. So in this table, you can see the classification of unpredictable adverse drug reactions, which can be classified as intolerance, idiosyncrasy, allergy and a pseudo-allergy. So intolerance means occurs at very low doses and is not due to underlying abnormalities of metabolism, bioavailability or excretion. Example is acetyl salicylic acid or aspirin-induced tinnitus. Then idiosyncrasy means it is unrelated to the intended pharmacological action of the drug, is reproducible and is usually due to abnormalities of metabolism, excretion, or bioavailability. An example is primaquine-induced hemolytic anemia in G6PD deficiency. Then allergy. Allergy is mainly immune mediated. It is mainly classified into four types, that is type 1, type 2, type 3 and type 4. Type 1 is known as IgE mediated, type 2 is known as cytotoxic, type 3 is immune complex mediated and type 4 is delayed hypersensitivity. So example for type 1 is anaphylaxis, type 2 example is thrombocytopenia anemia, type 3 serum sickness, vasculitis, type 4 examples include benign drug exanthems, DRUS syndrome, AGEP syndrome, contact dermatitis. So AGEP syndrome means acute generalized exanthemus pustulosis. Then DRUS syndrome means drug reaction with eosinophilia and systemic symptoms. Next is pseudoallergy. It is similar to type 1 allergic reactions with a different pathophysiology. The pathophysiology in the sense due to the direct mediator release of an histamine from mast cells and basophils. Example is opiate-induced urticaria. So we'll discuss in detail about drug allergies. Drug allergies are one type of ADR and are defined as an immunologically mediated response to a pharmaceutical and or formulation or excipient agent in a sensitized person. This definition implies that the reaction can have both immunoglobulin, that is IgE mediated, and non-IgE mediated mechanisms. Okay, these are the four types of hypersensitivity reactions. Type 1, which is IgE mediated hypersensitivity. Type 2, IgG mediated or known as cytotoxic hypersensitivity. Then type 3 is mainly immune complex mediated and type 4 is delayed or cell mediated hypersensitivity reaction. Classification of immunological or hypersensitive reactions. As I have already mentioned, there are mainly four types of hypersensitive reactions. So we will discuss in detail the mechanism and the signs and symptoms with examples. So type 1, also known as immediate. Mechanism is drug or IgE, that is immunoglobulin E, complex to the mast cells, release of histamine and leukotrienes. Then symptoms include pruritus, urticaria, bronchoconstriction, angioedema, hypotension, shock. For example, penicillin anaphylaxis. Type 2, also known as cytotoxic. Mechanism IgG and complement binding to red blood cell. Cytotoxic T cells lyse the cell. Then signs and symptoms include hemolytic anemia and thrombocytopenia. For example, associated with the cephalosporins, penicillins and rifampicin. Type 3 or otherwise known as immune complex mediated. Mechanism is drug antigen and IgG or IgM form immune complex, and this immune complex attracts macrophages and thereby complement activation. Then examples include cutaneous vasculitis, serum sickness, for example associated with chlorpromazine and sulfonamides. Type 4, also known as cell mediated or delayed type. Mechanism is by antigen presentation with major histocompatibility complex proteins to T cells and cytokine and inflammatory mediator release. Then signs and symptoms include usually occur after 7 to 10 days, macular rashes and organ failure including Stevens-Johnson syndrome and toxic epidermal necrolysis, for example associated with neomycin and sulfonamides. How to identify an ADR? In both the inpatient and outpatient setting, a patient's new or worsening symptom may be the first sign of an adverse drug reaction. Common laboratory tests can also assist in identifying an ADR. A new order for a serum drug level may alert the practitioner to investigate whether an ADR caused by drug toxicity or treatment failure is occurring. Laboratory monitoring can help determine improvement or decline after a change in therapy. When initiating a new drug therapy, it may be helpful to obtain baseline laboratory values in anticipation of an ADR. For example, baseline liver function tests are obtained before initiating therapy with a statin in anticipation that the therapy may cause an increase in these laboratory values, potentially warranting discontinuation. Orders for new medications may occasionally alert the pharmacist that an ADR has occurred. Medication orders such as naloxone. Naloxone is an opioid antagonist. Then flumazenil, which is a benzodiazepine antagonist. Then diphenhydramine, antiemetics, vitamin K, sodium polystyrene sulfonate, corticosteroids or antidiarrheals may be a sign that a practitioner is treating an ADR. Another way to identify an ADR is by reading the daily multidisciplinary notes in a patient's chart. Notes pertaining to oversedation, lethargy, and falls may be sign of an ADR caused by an analgesic, a sedative, or a muscle relaxant. Reports of a rash in a patient's progress notes may be indicative of an ADR and should be investigated for a drug-related cause such as an allergic reaction or yeast infection caused by the overuse of antibiotics. A causality assessment performed for each potential ADR can help determine future drug therapy options. Causality assessment of suspected ADRs. Causality assessment is a routine practice in pharmacovigilance. Although causality assessment cannot change possibility into certainty, it can provide a degree of likelihood to the relationship between a drug and an adverse reaction. One scheme used in the United States is the World Health Organization Uppsala Monitoring Center Causality Category Scheme. ADR is classified into one of 6 category terms as per World Health Organization Uppsala Monitoring Center. So they are classified as certain, probable or likely, possible, unlikely, inaccessible or unclassifiable, and conditional or unclassified. So here you can see WHO causality categories for ADRs. So certain means pharmacologically definitive with re-challenge if necessary. Probable or likely means reasonable temporal relationship, unlikely to be attributed to disease processes or other drugs with reasonable de-challenge response. Then possible means reasonable temporal relationship but could be explained by concurrent disease or drugs. No information on withdrawal. Unlikely means temporal relationship improbable. Then concurrent disease or drugs provide plausible explanation. Conditional or unclassified means an event which requires more data for assessment. Then the last one is unaccessible or unclassifiable, an event that cannot be judged because of insufficient or contradictory information which cannot be supplemented or verified. An important step in identifying an ADR and determining causality is to obtain an accurate patient drug list. Maintaining an updated, accurate medication history for each patient can also help prevent future ADRs. If the inpatient prescriber is unaware of the patient's home drug regimen, on admission, duplicate therapy may be prescribed. If admission and discharge reconciliation are not done, discharged patients may resume taking their home medication in addition to the newly prescribed therapy. This could result in an ADR or lead to rehospitalization. Assessing the timing between administration of the drug and the development of the reaction is important. Post-marketing surveillance and case reports are important tools that should be used when assessing ADRs for newly marketed drugs. Reporting a suspected ADR to the drug manufacturer and or the US FDA, that is Food and Drug Administration, will help identify a causal relationship between the drug and the adverse reaction if one exists. This in turn will provide valuable information or warnings to other healthcare practitioners and potentially prevent further ADRs in their patients. Several algorithms and probability scales have been developed to assist with causality determination. Two are more commonly used because of their simplicity and time efficiency. They are Narinjo ADR probability scale and Liverpool ADR causality assessment tool. So in this slide you can see the Narinjo ADR probability scale, and this scale consists of 10 questions and the answers can be mentioned as yes, no or do not know. Okay, so for any yes answer, okay, here you can see for each question if the answer is yes, for the first question if the answer is yes you need to give plus 1 mark, and if it is no, 0. And for the second question, for example, did the adverse event appear after suspected drug was administered, if the answer is yes you need to score plus 2. If the answer is no, you need to give the point as -1. Likewise, if a suspected reaction occurs, you need to answer all these questions and score accordingly. And at last, you need to find out the total score. Okay, you need to find out the total score. And if the total score is 9, then the ADR probability classification will be highly probable. And if the score is between 5 to 8, then it is probable. And the score is within 1 to 4, it is possible. And if the score is 0, doubtful. Okay, so this is how we can calculate the causality assessment using the Narinjo ADR probability scale. Now we will see the special populations or populations at a greatest risk. So the first one, pediatrics. Developmental changes affect the pharmacodynamics and pharmacokinetics of many of the drugs used in neonates, infants and children. For example, gastric emptying is delayed in neonates and infants, resulting in longer absorption time and potentially increasing the risk of an ADR. Volume of distribution also differs compared with adults, as does protein binding capacity, phase 1 and phase 2 metabolic pathways and glomerular filtration rate. Therefore, extrapolation of pediatric dosages from adult dosages should be avoided. Drug evaluation studies are seldom done, seldom in the sense very rarely done in this pediatric population because of practical difficulties and ethical concerns. In addition, the pediatric population often represents a small percentage of the pharmaceutical market, so clinical trials do not yield large profit expectations for drug companies. Drug classes most often linked to ADR related hospital admissions in neonates, infants, and children are cytotoxic drugs, corticosteroids, vaccines, immunosuppressants, and non steroidal anti inflammatory drugs. Withdrawal symptoms are often reported in neonates whose mothers chronically used medications such as opioids or benzodiazepines. One example of a pediatric ADR is anticonvulsant hypersensitivity syndrome, which is associated with the use of aromatic anticonvulsants phenytoin, carbamazepine, and phenobarbital. This delayed ADR presents as a triad of symptoms including rash, fever, and evidence of systemic organ involvement often affecting the liver, kidneys, CNS, or lungs. Management includes discontinuation of the drug and administration of systemic corticosteroids. Neonates, infants, and small children are unable to adequately communicate symptoms, making it difficult to diagnose an ADR. Underreporting of ADRs in pediatrics is of great concern because case reports may be the best aid in detection in this patient population. Pediatric ADRs are often undiagnosed or underdiagnosed because of the lack of published data. Educating healthcare providers to report known or suspected ADRs in this patient population is crucial to prevent future ADRs worldwide. Next category is geriatrics. The World Health Organization defines elderly as individuals 60 years and older. Of all the factors associated with ADRs in geriatric patients, polypharmacy is arguably the most important for pharmacist intervention. Cognitive problems also contribute to the prevalence of ADRs by leading to non-adherence. As the number of drugs increases, the risk of medication non-adherence also increases, further increasing the risk of an ADR. With advanced age come changes in drug disposition and pharmacodynamic responses. This increased pharmacodynamic sensitivity in geriatric patients, for example with CNS agents, can lead to ADRs even at low drug doses. Elderly patients may also have decreased renal or hepatic clearance, leading to pharmacokinetic changes and the accumulation of various drugs precipitating ADRs. Drugs that undergo significant hepatic first-pass metabolism may have a higher bioavailability and a quicker onset in older adults. Initiating these drugs at lower doses or at extended administration intervals can prevent an adverse drug reaction. Cytochrome P450 oxidation declines in this patient population, which increases the risk of ADRs when drugs are used that are substrates of these enzymes. During acute illness, serum albumin, which is a plasma protein, may decline in older patients, resulting in a larger unbound portion of drug available in the body. Cardiac output also declines with age, reducing blood flow to the kidneys and liver. The overall elimination of high extraction drugs, which depends on blood flow, is reduced, resulting in an increase in the half-life of the drug and its associated metabolites. Lean body mass and total body water decrease in geriatric patients, whereas the percentage of total body fat increases. This causes a decrease in volume of distribution for hydrophilic drugs and an increase in volume of distribution for lipid-soluble drugs. Tools available to assist in evaluating potentially inappropriate prescribing in older adults include the Beers criteria, then improved prescribing in the elderly tool, medication appropriateness index, and STOP, that is screening tool of older persons, potentially inappropriate prescriptions. Next special category is renal and hepatic impairment. We know that most drugs are metabolized by the liver and excreted by the kidneys. So impairment or failure of either of these organs can affect drug absorption, distribution, bioavailability, CYP metabolism, and clearance. Monitoring the laboratory values and adjusting the doses of drugs using these metabolic and excretory pathways can prevent an ADR. Physiologic changes in patients with hepatic impairment can influence drug dosing. The presence of ascites in a patient with cirrhosis can alter volume of distribution, affecting the bioavailability and elimination half-life of some drugs and potentially leading to an increased risk of ADRs. Decreased hepatic blood flow and the presence of portosystemic shunts can lead to increased bioavailability and serum drug concentrations, often necessitating a dose reduction in drugs such as antipsychotics, anti-anxiety agents, sedatives, anti-Parkinson drugs and antidepressants. Drugs that undergo extensive hepatic first-pass metabolism should be used cautiously in patients with hepatic impairment. Next one is genetic variations. Using pharmacogenomic testing to provide personalized medicine can maximize the therapeutic benefit and avoid or reduce the incidence of ADRs. An example is HLA-B Y701 screening for abacavir hypersensitivity. Pharmacogenomic testing for this allele before initiating abacavir therapy can reduce the risk of this specific ADR. Another instance of ADR prevention through pharmacogenomic testing is the highly polymorphic CYP2D6 gene. The conversion of codeine to morphine depends on CYP2D6 activity. CYP2D6 variants can be categorized as poor, extensive or ultra-rapid metabolizers. Poor metabolizers will be unable to convert codeine to morphine efficiently and may not experience adequate pain relief. This could be considered a type F ADR, that is due to the unexpected failure of therapy if genetic testing was not performed in advance. So the next special population is pregnancy. The FDA classifies drugs into 5 categories, that is A, B, C, D and X, based on their safety of use during pregnancy. So first one is category A. Category A means controlled human studies show no risk to the fetus. Okay, so the category A means completely safe for use in pregnancy. Examples are vitamins at a recommended daily doses, then thyroid hormones. Then category B means animal studies show no risk to the fetus, but no controlled human studies have been conducted. Okay, so category B means in animals there is no risk, but no controlled human studies have been conducted. Then selected examples are acetaminophen, cimetidine, aluminum hydroxide, penicillin, then insulin, clindamycin, ibuprofen in the first and second trimesters. Next is category C. Category C means human data lacking or animal studies show risk. For example, pseudoephedrine, simethicone, clotrimazole, senna, dextromethorphan, prednisone, aspirin, then hydrocortisone in the second and third trimesters. So category C means sufficient human data is lacking but animal studies show risk to the fetus. Then category D means human data shows risk but benefits may outweigh the risk. Okay, category D means there is positive evidence of human fetal risk, but the benefits from use in pregnant women may be acceptable despite the risk. For example, if the drug is needed in a life-threatening situation or for a serious disease for which safer drugs cannot be used or are ineffective. Selected examples are ibuprofen in the third trimester, then hydrocortisone in the third trimester, phenytoin, tamoxifen, lithium. Next is category X. Category X means animal or human data shows positive risk. Okay, these drugs are absolutely contraindicated drugs. Category X is studies, that is adequate, well controlled or observational in animals or pregnant women have demonstrated positive evidence of fetal abnormalities or there is an evidence of fetal risk based on human experience or both. So examples are vitamin A at doses exceeding the recommended daily allowance, then triazolam, lovastatin and medroxyprogesterone. Next topic is pharmacovigilance. Pharmacovigilance involves the study of drug-related injuries and making warning or withdrawal recommendations for pharmaceutical agents. It encompasses the detection, assessment, understanding and prevention of ADRs. The ultimate goal of this activity is to improve the safe and rational use of medicines, thereby improving patient care and public health since most ADRs are preventable. All suspected adverse drug reactions should be reported using the Suspected Adverse Drug Reaction Reporting Form. Pharmacists play a vital role in every step of the pharmacovigilance process, which can prevent patients from undergoing unnecessary procedures or taking unwarranted drugs. Rationale for ADRs monitoring. The process of collection of safety information begins with phase 1 of the clinical trial through phase 3 and even continues in the form of a post-market safety studies referred to as post-marketing surveillance. Pre-marketing safety evaluation of pharmaceutical products at the time of registration is inherently limited due to the following 3 reasons. So the first reason is median population and limited exposure. The population in the phase 3 clinical trials is limited and very selective. Narrow patient population, as many types of patients with different characteristics are often excluded from studies such as children, elderly and pregnant women, then patients with diseases other than the one being treated and patients using other drugs concomitantly. Prevents the identification of adverse effects caused by the interaction of two or more drugs given at the same time. So the next limitation is short duration of clinical trial. The duration of a clinical trial is too short. Such studies do not allow the detection of adverse effects that appear after long periods of use or exposure, especially with a chronic medication. And the next disadvantage or limitation is geographical differences. Differences between countries which led to variation in patient factors, variation in drug utilization among healthcare professionals, and variation in drug manufacturing processes used can influence pharmaceutical quality and composition of locally produced products compared to those imported outside the country. Now we will see about post-marketing surveillance. For the above stated reasons or the above stated limitations, it is obvious that not all safety related problems associated with the drug may be detected during pre-marketing test and evaluation. The goal of evaluating ADRs is to increase patient safety by preventing harm. Therefore, safety monitoring of a drug is required throughout the life cycle of all medicinal products. Now we will see about the ADR management, and these are the various steps involved in the ADR management: risk minimization, recognition and timely detection, then other modalities such as discontinue the offending drug, then modify the medication. So under risk minimization, understand patient views about medication therapy, educate about the benefits of treatment, then inform patients about potential ADRs and the management strategies should any occur, then ensure an updated and accurate medication list, use fewest drugs as possible, then utilize decision support software to help prevent ADRs, start with low doses and frequencies and slowly titrate as tolerated, initiate less potent agents, agents with direct mechanisms of action, or alternatives with lower adverse event incidence. Avoid or reduce the use of interacting medications. Always elicit concomitant drug history such as over-the-counter medicines, medicines prescribed by other prescribers or providers including home remedies, herbal medicines and alternative system of medicine. Prescribed dosage forms with minimal systemic exposure, for example creams and patches. So these all are the methods by which we can prevent or reduce the ADS. So we have completed or we have discussed about adverse drug reactions, classification, then preventive methods. So I hope you all like this video. Thank you everyone for watching this video. Please like, share and subscribe. Have a good day.